Thank you for the biography. Thank you. Firstly, my disclosures. I have no disclosures except for the fact that I am the PI of one of the studies which I will present, and I always think you've got to take it a grain of salt when somebody's actually interpreting their own data. And I also am a recipient of grants for research into this area, which may also cause subconscious bias. I'll talk a little bit about the FDA statement, a little bit about the animal data, but I haven't got time to go, and I'm not an expert on the animal data, so I won't go into that in detail. I'll talk more about the human clinical data and then a little bit about what next. So this is the FDA statement which came out recently, and in fact this is actually just the first paragraph. The statement in its entirety is several pages long, and the vast majority of the statement is very well written and very well balanced. Unfortunately, most people are only going to read the first sentence, and they don't go on to then look at the statement where the statement actually qualifies what is said in the first sentence. So this is what it says, basically warning repeated or lengthy general anaesthetics and sedative drugs during surgeries, procedures, children younger than 3 years or pregnant women may affect the development of the children's brains. The FDA came under a lot of criticism for presenting this, but they had to write something. And really they were damned if they did, damned if they didn't, and this is probably the best that they could come up with. Now, it is a huge topic of neurotoxicity. A friend of mine, Andreas Lopke, recently published this, where he's looked at all the different papers that have been written, that's in blue, and then the review articles in red. And you'll notice a few years there's actually more review articles than there are original papers on this topic. He also somewhat optimistically thought there'll be over 100 papers published this year on this topic, and he may be correct. But what I'm going to focus the talk about today is this problem that there are two observed phenomena. One is that the preclinical studies show that anaesthetics have an effect on brain development, and secondly, a large number of clinical studies which show that surgery in infancy is associated with greater risk of poor neurobehavioural outcome. But we don't know whether they're two separate entities or whether they're somehow linked, and what we're seeing in the preclinical studies is causing what we see in the clinical studies. And this is a very difficult problem to try and solve. SmartTots is an organisation which is a collaboration between the FDA and the IARS, which you'll be familiar with, but this issue has become very emotive amongst paediatric anaesthetists. So the Europeans have generated SafeTots instead, where they've argued that this is an irrelevant topic. They said, if there'd been a problem, we would have seen it, so therefore it can't be a problem. They said we should concentrate on all the other important things. And in an editorial, which I'm sure anesthesiology would never publish, two paediatric anesthesiologists went on to say the difference between what's seen in European studies, which show no difference, and American studies, which show a difference, is because the schools are basically better than Europe, and here, and somewhat distressingly, or rather a desperate desire to keep and expand the NIH funding for the research group. I was somewot flabbergasted to see that a reasonably respectable anaesthesia journal would publish something like this. Anyway, the animal data. Most of the animal data started with a study in 1999 from Economou, who basically showed that if you give MK801, which is similar to ketamine, you get lots of apoptosis in a 7-day-old rat. Since then, there's been an explosion of studies, and it's now a well-defined morphology. In summary, you get accelerated apoptosis after about 3 to 6 hours of anaesthesia. It happens in the cortical layer 2 and 3 and cortical layer 5 with pyramidal neurons, but also the interneurons and oligodendrocytes. It's estimated it's about 2% of all neurons are affected. But you also get impaired hippocampal neurogenesis, and that may depend on the cell age, which may explain why you get a different effect at different ages. But you also get quite a lot of changes in the dendritic spines and synaptic density, and that occurs rapidly and may persist. The mechanism, nobody quite sure what the mechanism is. It was originally postulated to be a use it or lose it mechanism, that you're born with a whole lot of neurons, they talk to each other, that's how they generate and survive, but if there's no one to talk to because you anaesthetise them, then they all suicide. So that was a sort of use it or lose it theory, which is probably not correct. There's a whole lot of mechanisms which have been shown to be cause the apoptosis. It may be altered neurotrophin signalling, mitochondrial dysfunction, neuroinflammation, changes of the interneuron phenotype or tau phosphorylation, and nobody really knows whether these are all linked or whether they're all separate mechanisms triggered by the anaesthetic or the anaesthetic state. It's seen with all general anesthetics, but probably not the alpha-2 agonists, although that's a little debatable. There's a bit of recent evidence for or against it, and probably not with xenon. The longer you're exposed, the greater the effect. And this is a graph which shows all the different papers that have been published. The animal papers are the small dots, and the human are the large purple dots. The ones that are above the line are the ones which have shown an effect. The ones below the line, the ones that have not shown an effect. Red is morphological and blue is functional. And if you just look at, this is the older, or the longer the exposure, and you can see that it's sort of the longer the exposure, the more likely you're to see an effect, but it's very difficult to actually draw a line there and say, under that exposure, you don't see an effect. So the longer the exposure, the more effect, but it's very hard to say, with this exposure, you don't see an effect. Similarly, with age of exposure, the older the animal, and this is sort of adjusted for human years, it's sort of hard to see which age is most at risk, even though classically we talk about the P7 rat or we talk about the infant monkey. Most of the experiments have been in that sort of neonatal period, and there's very little data for older animals. And certainly if you pull them all together, which is somewhat artificial, you don't really get a strong sense that there's a particular age which is most at risk. So what do we know from the animal studies in summary? In the animal studies, many general anaesthetics have a variety of effects. The effects of the regions vary with dose, agent, and the age of exposure. It's most common with the GABA agonists and the NMDA antagonists. Changes are greatest with longer exposure. There might be multiple mechanisms, and there's increasing evidence for long-term neurodevelopmental changes in rodents and in non-human primates. But how does this translate to humans? Well, firstly, there's absolutely no reason to suspect that the changes that you see in animals would not occur in the human brain if they're exposed to sufficient doses of general anaesthetic. So there's a common perception, say, oh, it just doesn't happen in humans. I mean, that's nonsense. If it happens in everything from a nematode to a primate, it's ridiculous to say that it wouldn't happen in a human. So if you give enough anaesthetic to a human when the brain is developing, you will see some morphological changes. It's just illogical to say that that's not going to occur. The question is whether it actually matters and whether that translates clinically to anything that matters. There are precedents in the animal models for being irrelevant to humans but that we know of. It's hard to predict what age and what dose the children are at risk. We have incomplete data on which neurological domains to look at in humans. We don't know the impact of surgery, whether it modulates it. And there are many modifying factors when you translate animal data to humans when it comes to neurodevelopment. And if you think of a neurological injury in a human brain, it depends on the timing, the type of the insult, and the site of the insult. And depending on the combination of those, you either get complete recovery due to plasticity or a slightly different combination. You might injure the building blocks and you might get a permanent severe injury. So it's very much determined on those sort of various combinations. And then there's an overwhelming influence of genes and the environment, which can modulate it as well. So it's very difficult to translate what you see in an animal as far as a neurological injury to what you might see in a human. So the human data. Well, firstly, for many years it's been known that major surgery in the neonatal period is associated with poor outcome. And there are a number of studies which are in the neonatal literature and the surgical literature which show that all these major operations in neonates all have an increased risk of neurobehavioural outcome. But these kids all have a lot of other things going on. They're premature, they're septic, they've got syndromes. So for many years people didn't even think that anaesthesia might be the cause for this association. In the last 10 years, there have been a number of studies which are designed specifically to look at the problem of neurotoxicity of anaesthesia. There are birth cohorts, there are retrospective population-based studies, and there's ambidirectional birth cohorts, and there's 1 or 2 trials, or 3 trials. They've looked at a number of different outcomes, the diagnosis of a learning or developmental disorder, school grades, psychometric testing, and there's a couple of studies that have looked at MRI imaging. If you look first at the studies which have looked at the diagnosis of learning disability or ADHD, there are 2 groups which have published a number of studies. The first, the Mayo group, and they showed in their birth cohort an increased risk of increased risk of learning disability and ADHD with multiple exposures at less than the age of 2, but no risk with a single exposure. They repeated the study a few years later, and they found the same with children exposed less than the age of 3. DiMaggio et al. In New York and Lena Sun's group have done similar work looking at children of hernia repair, and they also showed weak evidence for an association between hernia repair and diagnosis of ADHD or a learning disorder in greater if multiple exposures. But more recently, and I'll focus this talk on the more recent papers, this came out in ANA by Caleb Ng from Lena Sun's group, where he looked at the age of exposure between 0 and 5 in children who had 4 different procedures. So it was a Medicaid database from New York and Texas, and they had 38,000 children who had surgery before the age of 5 who had a pylomyotomy, inguinal hernia, circumcision, or a TNA, and they matched them to 192,000 controls. And they looked at diagnosis for any mental disorder and then a sub-analysis of developmental delay in ADHD. And they showed overall a hazard ratio of 1.26, so there's reasonable evidence for an association between having any one of those surgeries and developing some mental disorder. And if you look at their sub-analysis, it persisted in if you look just at developmental delay or the diagnosis of ADHD. Then they did an interesting thing. They divided them up into the different age groups that they were exposed. So this is from neonates all the way up to 5-year-olds, and they're divided up into 6-month groups, and the reds are the exposed and the blacks are the unexposed. And basically, if it's a Kaplan-Meier plot, if you're red, if you're below the black line, that means things are bad. And you can see that across all ages of exposure, the children who were exposed to surgery did worse than the children who didn't have surgery. So this is quite an interesting paper because it's showing that the risk is potentially up to the age of 5, and the risk at the age of 5 doesn't seem to be particularly greater than the risk in the neonate. They did the same thing looking at the different surgeries. So this is each surgery. This is pylomyotomy, circumcision, inguinal hernia circumcision and TNAs, and all the different age groups. And this is any mental disorder. This is developmental disorder or a ADHD. And you can see it really didn't matter what type of surgery you had, there was an increased risk. So no matter what age you were, no matter what type of surgery you had, you still had an increased risk of association. Another way of looking at outcome is to look at school grades. So a Danish and an Iowa study some years ago did this with a relatively small sample size in Iowa, but a big sample size in Denmark, and they found weak evidence for an association between surgery in infancy and poor grades, with very little evidence for the association if you adjust for confounding. But they found a higher incidence of non-attainers. That's if you got to school, you did as well whether you're exposed or not, but if you're exposed to surgery, you're more likely to never get to school in the first place. 2 Canadian studies were published last year in anesthesiology, and they're very interesting. We talk about replication. These are 2 studies that are almost identical, done almost at the same time in 2 different states in Canada, and the 2 groups didn't actually know that the other group were doing it. So it's like the perfect replication study. And they used as their outcome something called the EDI, which is a test which is it's a 103-item test that a teacher does to see whether a kid's ready to go to school, and it has 5 different domains. In the Ontario study, they found 28,000 children who had surgery before they went to preschool, and they matched them to 55,000. They excluded children who were already at risk. They matched them for potential confounding factors, and their primary outcome was vulnerability. That's if a child scores in the low 10% in any of those 5 domains. And then they did a regression adjusting for known confounders. And they found weak evidence for a small difference. So there was a slightly higher proportion of children who got in the lowest 10% in those who had surgery. The difference was only seen in the greater than 2 age group, but they didn't really have sufficient power to comment in the younger children. The Manitoba group was similar, slightly smaller state. They had 4,000 children having surgery, 13,000 matched controls. They excluded children who were at risk, like the other study. They matched them, like the other study, although slightly differently, and they once again did a regression analysis. And in their outcome, they looked at the total score, and they showed strong evidence for a small difference between the group, a bit like the others, but interestingly, the differences were in different domains. They showed no evidence for a difference between single and multiple exposures, but the difference was greater in the older children. A Swedish study came out at almost exactly the same time in JAMA Pediatrics, and they looked at 2 million Swedish children born between 1973 and 1993, and 33,000 children had had 1 anaesthetic. and they matched them with 160,000 control children, and in addition they had about 3,500 who had had multiple surgical procedures. The outcome was their school grades at the age of 16 or their IQ test, as most Swedish boys go into the army and they all get an IQ test as they go into the army. I'm not sure if they keep them if the IQ is high or low, but anyway, they all get tested. They did an adjustment for known confounders, and a bit like the other studies, they showed that one exposure before the age of 4 was associated with a mean difference of 0.4% of your school grade. So you were 0.5% worse than the other kids, and about a 1% lower IQ score. If you look at the age of exposure, they're really, you could maybe perhaps it was a bit worse in the older children compared to the younger children, but not that was really a secondary analysis, so you've got to take that with a grain of salt. And if you look at the number of exposures, once again, maybe a bit worse with more exposures, but not much power, and once again, it was a sub-analysis, so you've got to take it with a grain of salt. But if you look at the effect of anaesthesia compared to other things, so this is the effect of anaesthesia, a very small effect, but this is the effect of being a boy or a girl or being born in December as opposed to January, or whether your mum went to uni. So that's about there's a tenfold greater difference as whether you're a boy or a girl compared to whether you had anaesthesia or not. So the effect of anaesthesia or surgery is very small compared to everything else that goes on in life. Several studies have looked at psychometric testing, and they all tend to be very small studies, and they've all shown an association between a variety of things such as cognitive function, memory, listening comprehension, and language defects. Probably the most comprehensive study, once again from New York, is the PANDA study published in JAMA last year. And they used a sibling-matched ambidirectional cohort study. They had 100 sibling pairs. They tested when they were 8 to 15 years old, and they were healthy at the time of exposure, which was having exposure for a hernia repair at less than 36 months. Their anaesthetics mean duration was about 80 minutes, and their primary outcome was IQ, and they had a range of other secondary outcomes. Now, IQ is normalised to have a mean of 100 and a standard deviation of 15, and in the exposed and unexposed group, you can see there's no difference, 111, 111. It's interesting, even though your mean IQ for the population is 100, the children in this particular study had an IQ of 111. That tells you something about selection bias, that smart families tend to come back to have their children tested. With a difference of a 0.2. Actually, in some states, the dumb families come back, and in New York, the smart families come back, so go figure that. In Australia, the smart families tend to come back. So, if you look at performance IQ, verbal IQ, very, very small differences, and the confidence interval is between plus or minus 3. Now, you wouldn't really think someone's got a problem until they're 1 or 2 standard deviations away, which is about 15 points. So if your 95% confidence interval is minus 3 to 3, and clinically you haven't got a problem unless it's 30 or so, this shows an extraordinary degree of precision about suggesting that there's no problem. They had a range of other secondary outcomes, and they found very little evidence for any difference in either of those. They also looked at the age of exposure, and those who were exposed slightly younger compared to older, they didn't see any difference. And those who tended to get a bit of a longer anaesthetic compared to a shorter anaesthetic, they didn't see much difference either. There are 2 studies which have looked at MR data, and I know there's some more studies which are underway. The first study from Cincinnati by Bacalhau, published in Pediatrics a couple of years ago. They looked at children who had anaesthesia at age less than 4, matched control group, had an MR somewhere between the age of 5 and 18 for another study, so this was a sort of coincidental secondary analysis. 53 subjects in each group. They found no loss of white matter, no loss of grey matter where they expected to see it in the thalamus and the retrosplenium, but they did show an association between lower IQ and listening comprehension with loss of grey matter in occipital cortex and cerebellum. But they really, in their paper, they admit they've got no idea what this means. More recently, Block published a paper in anesthesiology looking, once again, at MR data. Children who had anaesthesia in infancy had an MR at the age of 12 to 15, 17 subjects in each group, so very small groups. They showed a low total white matter, but no difference in grey matter. And I find these MR studies quite difficult to interpret because often they have a huge number of analyses where they're looking at every single bit of the brain with every single analysis possible. And if there's only 17 in each group and they've got 50 or 60 analyses, it's very difficult to actually unpick what it means. Summary of the human cohort. I can see Tim nodding vigorously. So, I'm slightly sceptical of MR data too. We did a study years ago where we looked at MRs in children who had had hernia repair before and afterwards, and we showed the MRs to one neurologist and he looked at them and said there's absolutely no difference. We showed the MRs to another very eminent neurologist who looked at them and said, oh my God, there's such a huge difference. And I thought, well, it's very subjective with converting it, trying to interpret MRs. So the summary of the human cohort data, good evidence for an association between major surgery in neonates and increased risk of poor outcome. Good evidence for an association between exposure in early childhood and a very small difference in school grades. Good evidence for an association between single and multiple exposures and learning disability and diagnosis. Mixed evidence for an association with deficits in cognition, memory and language, and poor evidence that the effects are greater for multiple exposures and little, if any, evidence that the effects are greater of an infant. So in summary, from the cohort data, there doesn't seem to be that the injury is greater in infants compared to older children, which it goes slightly against what you might expect to see from the biological data. The other thing that's quite interesting is you can actually get an increase in incidence, something like ADHD and autism, without differences in cognition. So the studies which show that there's no difference in cognition and IQ are not incompatible with a study which shows there's an increased risk of ADHD and autism. Now, that makes it quite difficult to study this field because ADHD and autism, even though they're common, they're not that common, and it's a binary outcome as opposed to IQ, which is a linear outcome. So trying to unpick it is much harder if you're looking at the incidence of ADHD and autism. But the limitations of the cohort study, well, obviously confounding is the biggest limitation. Children have procedures because there's something wrong with them, and the thing that's wrong with them might be associated with something else which gives them poor outcome. The illness itself might be, or it could be the surgery, it could be the effect of pain. There's all sorts of things that we do to kids in the perioperative period which could injure the brain without being neurotoxicity. And no matter what you do, no matter how many adjustments you made, no matter how much you try and control cohort data, you can never completely get rid of confounding. And just getting a bigger and bigger and bigger sample, the confounding just grows and grows and grows with the sample. So unfortunately, due to confounding, any association that we see in these studies, there's always a risk that it might be purely due to confounding and not due to anaesthetic toxicity. On the flip side, because we're not really sure what domain to look in, and because we're not quite sure which group could be the most at risk, if you don't see an association in a big cohort study, it doesn't rule out there being an association in one of the more at-risk groups or in a domain or one of the subdomains. So cohort studies are tricky to interpret. There's one trial which is almost finished, that's the GAS trial. The preliminary results of the 2-year outcome was published in The Lancet recently. It's a randomised, assessor-blind, multi-site equivalence trial for infants who had hernia repair less than 60 weeks. We excluded kids who were at risk of poor neurodevelopmental outcome, and we randomised to a wake regional anaesthetic, mostly spinals versus sevoflurane. The primary outcome is the WIPSI at the age of 5, which is a full-scale IQ. The last kids are getting assessed next month, and so we'll have the results of the 5-year outcome probably in 3 or 4 months' time. The secondary outcome was at 2 years. We did the Bailey 3, which is like the WIPSI in that it has a mean of 100 and a standard deviation of 15, has 5 different domains, and we were particularly interested in the cognitive domain. The analysis that we did an as per protocol analysis because it was designed as an equivalence trial, and we used multiple imputation to try and account for missing data, but we also did intention to treat and complete case analysis as well. 700 children randomised, failure rate of 19%, loss to follow-up of 15%, which is about standard for these sorts of studies. And the average anaesthesia time was about 55 minutes. The surgery time was only 20 minutes, but the anaesthesia time was 55 minutes, which was a bit embarrassing to find. And if you look at the results, this is the difference between the 2 groups, and you can see whether you use as per protocol or intention to treat or complete case with multiple imputation, the difference is tiny, and similar to Lena's study, the 95% confidence intervals are all within what you would regard as being normal. And if you look at them for all the different scores, once again, no evidence for difference, and if you plot it here as our predefined boundaries of equivalence, the 95% confidence will always in there. Limitations, it's only an hour of anaesthesia. That may not be enough to see an effect. And it's only a 2-year outcome measure, which is an imperfect predictor of future function. And there are some things like higher executive function you just can't measure in a 2-year-old. In context, the results of this particular trial so far sort of shows there's increasing evidence that less than 1 hour of exposure is not a problem, but there's very little data on longer exposures. So if we go back to the FDA statement, I think firstly, the use, it's correct in say warning that lengthy general anaesthetic is probably the problem. There's increasing evidence that short duration is not a problem. Younger than 3 years, this is a number which is really plucked out of well, no, the FDA almost admits that they're not quite sure why they chose 3 years. I guess it was based on some of the preclinical data, but really it's a very woolly 3 years, and you should take that with a very big grain of salt. And the issue of repeated anaesthetics is an interesting one. And it could be that, yes, multiple hits cause more injury, or it could be due to confounding. So just if you model the effect of confounding, if it's due to confounding by implication, do you see a great effect with more anaesthetics? And the answer is yes. So if you just model it quickly like I've just done here, if you assume that 5% of children have ADHD, you assume all children have a 10% chance of 3 different surgeries. And then if you say for just one surgery, it's more likely to happen if the children have ADHD. So if they haven't diagnosed ADHD yet, but it's a bit of a rotten child who needs to have his teeth done under anaesthesia because he's sort of developmentally not quite right, but they haven't had a formal diagnosis, then you can imagine that he's more likely to have surgery because he's brewing ADHD. So what impact would that have? Well, if this is the relative risk, and if that surgery is 4% versus 2%, then you can see the relative risk increases with the number of surgery, and it's even more marked if there's a particular surgery which is more likely to happen if you've got ADHD. So the fact that you see an effect more frequently with multiple procedures could actually be a sign that it's due to confounding. So the current recommendation is, by most societies, is don't delay or avoid short procedures. Consider delay non-essential lengthy procedures, which is easy to say because we don't actually do non-essential lengthy procedures. Nobody's got any idea how long the delay should be. Should it be 1, 2, 3, 4 or 5 years? And don't generate a real risk by using an untested inadequate anaesthetic to avoid a still large theoretical risk. So most societies, paediatric anaesthetic societies around the world, have this as their current recommendations. What next? We need to better understand the mechanisms. We need to identify any safe agents, if there are any, and there's a number of mitigating agents that are in the pipeline, which I won't have time to talk about. We need better cohort data to define those at risk and to identify the domains that we need to study. And it'd be nice if we had some biomarkers. But the problem with biomarkers is our history of finding good biomarkers for neurological injury is not particularly good. And you've got to prove that the biomarker is correlated with long-term outcome anyway. So you've still got to do the study with the 10-year follow-up to see if the biomarker actually is predictive. The next trial we're doing is we're looking at infants who have greater than 2.5-hour anaesthetics, and we're comparing a mixture of dexmedetomidine, remifentanil, low-dose sevoflurane versus standard-dose sevoflurane. This trial's already started in the States and in Australia. It'll probably take another 10 years to get the result from this trial. Have we actually solved the problem whether are these 2 related phenomenon, or is it one single phenomenon, or are they unrelated phenomena? Unfortunately, in 10 years, we haven't come a long way to actually unpicking the problem as to whether these are related or not. But I'd leave you with, the second last point is from an editorial by Ted Eger, who we mentioned this morning. And years ago, they were worrying about the toxicity of halothane. And he wrote this nice letter or editorial in Anesthesiology, basically saying, although halothane or enflurane or diazepam may not be toxic, you cannot construct a study that will conclusively document non-toxicity. Long ago, my father warned me that I could not disprove the existence of dragons. So what he's basically saying is, if you show evidence for toxicity in preclinical studies, it's impossible to do enough clinical studies to actually completely exclude toxicity. And so, to some extent, we may never really know whether these 2 factors are related or not. The wider context, this neurotoxicity debate has actually raised other interesting issues. One is, if it's not the neurotoxicity, then why are these children doing worse? And from a pharmacology point of view, it's highlighted a very interesting question of, well, what actually is the optimal anaesthetic for an infant? And there's a couple of provocative editorials saying, well, if you put aside the issue of neurotoxicity, what are we trying to, we actually don't know much about pharmacology in infancy and neonates anyway. And so it's opened up this whole field where we've got no idea how much sevoflurane a neonate or an infant should have in any case. And this is probably the most exciting aspect of the neurotoxicity issue, is it's making paediatric anesthesiologists think, what are they trying to achieve? How much should they actually give for children? And thank you very much.